I should have done better. No, you did the best you can, and that's all I expect. So it is week 5. This is actually probably my favorite week, but it's a long week. So I'm going to warn you, it's going to run.
Hello and welcome to
So some of you who need to get off early, I understand today. I might run till 20 after, 25 after 5. I know some of you have responsibilities, but it is a really jam-packed full week. Cardiac respiratory. You're talking about something that you'll see in every level patient, and I'm going to try to get you thinking about it. It's a lot of stuff to cover, and I'm telling you, your HESIs and your NCLEX, cardiac respiratory is those big systems that they really focus on. So I try to pay attention to it. Even the Cahoots has 59 questions this week. So if it's going on and you can't stay, I get it, I understand, okay? So we do have opening the congenital heart, and we also have the cystic fibrosis, which opened, that you have till next week to get it in, but I always tell you it's there, available. I would say this week, do it after class. It just feeds in those gaps of information because I'm not going to teach what's on a case study when I know that you're all going to be looking at them. So let's go ahead and let's get our PowerPoint. Remember, any point you're not understanding, especially when we get to cardiac, let me know. I'm going to try to make cardiac as simple as a garden hose and what happens if you put a kink in it. How does that sound? Everybody understands you kink a hose, what happens? Backwards, it's going to get pressure, right? Blood flow goes backwards. And then where does the blood go? Out any holes that are there, right? Or if you haven't screwed it on tight enough, it's going to come out fitting at the end. So that's the way I'm going to make you think about cardiac. So we're going to start with respiratory. So we have infections that could be in the upper. This is your sinuses. This is your ear infections, whatnot. And then your lower, which is more of your, pneumonia, something atelectasis, consolidation of mucus in the lower lobes. Most of the time, we talk about respiratory. It's all upper respiratory are viruses. And usually that's the way we'll treat them. Many of you will take your children in or have taken them to the doctor, got 104 fever, and they're coughing and full of mucus, and I need antibiotics. And the doctor says, no, it's probably a virus. Let's give Tylenol and Motrin and plenty of liquids and rest, and that should take care of it. Well, 3 days later, you're still continuing with the same things. That's when they'll put you on some sort of antibiotics because kids are always with some sort of cough and mucus. That's just part of what children do. So the reason why we don't put them on all the time antibiotics, then they wouldn't work when we really needed them. And that's the point. Now, one of the things we think of viruses and upper respiratories is something called respiratory syncytial virus, RSV. Now, RSV for me and you is a common cold. It's a virus. How do we treat it? Tylenol, Motrin, and we're going to keep our nose clean, whether suctioning or blowing our nose. And of course, plenty of liquids to get those secretions thinned out. Now, if this is an infant below 6 months old, their hardest thing in life is sucking, swallowing, and breathing. Just taking a breath or taking a bottle is a lot of effort. So put a little mucus in those nasal airways. Guess what happens? They're going to start struggling to breathe. And also there is a low-grade fever. And of course, you don't like a fever because you just don't feel well. So RSV for a normal, healthy, newborn, young infant is, just keeping that nose clean and keeping the fever down and making sure they get plenty of fluids in them, which is their formula or breastfed. We don't just give water. We don't give ever any empty calories. We don't. We want to give them what they need, unless they're already too big, okay? Now, what if you were a child with a cardiac condition, and now you put the mucus in the nose, and now they're really struggling to breathe? We don't want these children to get RSV. So we can give an immunization monthly, and it's called Synergist, Synergist, Synergist. It's monthly, given through fall to early spring. once a month, and it's to those children who are immunosuppressed, sickle cell, cystic fibrosis, of course, any cardiac, premature children with, respiratory illnesses already, and it does prevent them from getting it. So that is one vaccine you need to know. Now, did you all get that matching sheet that I sent you out on your announcement? It is A through Z, cardiac and respiratory. And I sent it on the announcement. And after class, try to go back and fill it out. Those are all the terms you need to know. So if you know those terms, you're going to know respiratory, and you're also going to be knowing cardiac. If you didn't get it, I'll post it in the chat box after I get off of the PowerPoint. Just please, somebody remind me to do it, because sometimes I will forget. Must be that senior mind I have at times. Now we know upper respiratory can go into that strep and staph, and that's, again, if it's a virus that continues, then we're going to be assuming that it probably is something else, and we'll treat it with antibiotics as much as we should. Now, a concept, children, they're born, and they're born with mom's immune system. Now, mom's immune system are good, but that immune system wears off, right? Just like your red blood cells, your hemoglobin, hematocrit, it's mom's. You're born with it really good, but your body's not going to start making new antibodies, new blood cells, until about 6 months old. And of course, we're giving those immunizations at 2 months, 4 months, 6 months. We're loading them up with all those immunizations that can really take a toll on the body, and a lot of times can cause death because they're that severe. So in the very early children, 3 months and less, you really shouldn't see them getting sick, okay? And if they do, we take it seriously and we load them up immediately, antibiotics. We don't even question it because there is no immune system. There is nothing to fight. So we will make sure at least they're covered with it. Now, after 3 months, your body's been hit with a couple little upper respiratories or little viruses. You've gotten antibiotics, but your immunizations, but you're going to see them start getting more sick. Ear infections are huge. Sore throats, everything in the mouth, right? And you're going to see that cough, nasal mucus, etc. When you get to the toddlers and a little bit higher, what did I tell you what these kids do? They go to daycare, they go to school, they swap spit all day, which means my infection goes to this child, to the next child, to the next child. And I think it describes it very well. It's what kids do. Explore the world in their mouth, everything in their mouth. Decrease stress through their mouth. The mouth is very important then. As they get old, and most of those are virals, a lot of ear infections and sore throats again. Now, after 5 years old, it's more of your bacterial. That's when you start getting into those strep infections and the mycoplasma infections. And as we're getting all of these diseases, your body is building up those antibodies. Your immune system is becoming stronger and stronger and stronger. So many parents say, well, I should just pull them out of daycare and I should stop working because, they're just getting sick. Well, that's really not a good suggestion. The suggestion is they need to get these little illnesses so that they do build up a good immune system, because by the time they go to school, what is their immune system looking like if they've gone to daycare and have had all of these little illnesses? Is strong now, and then they'll be able to be in school and learn what they need to do. So again, increases immunity with their age. Now, ear infections and all of this upper airway stuff. Well, the diameters are short and they're wide open and they're straight. So eustachian tubes. I've mentioned ear infections a couple times. You put mucus in the nose and in the oral pharynx, and that's where your eustachian tubes dump out in the back of the throat. And guess what? Mucus is a way to escape, just like that garden hose, right? It's a way to go. It's a pathway that's open, no resistant. Mucus goes in. What happens? Ear infections, right? So what do you see with children who are sick? Whether it's an ear infection, whether it's just an upper respiratory, sore throat. Well, number one, these children are going to stop eating. And they're going to be not playing, sitting in the corner and maybe sleeping when my kid don't sleep like that. That's the time where you say, something's wrong with my child. I mean, if it's acute pain, you can tell sometimes, even on the younger kids, they might be banging their ear or sticking their hands in their mouth. They're telling you the location of where that pain's coming from. Sometimes they bang their ear on the bed again, or the hand is telling you, my ear hurts. So look at those cues, because these little infants, really can tell you those things. I mean, they're not eating, we can see. Vomiting, diarrhea, we can see. Abdominal pain, you're going to see them, with a tense abdomen. You touch it, it's going to hurt. Or you're going to see their legs moving, and they're clenching it. And you're going to see, if you see a cough, if you see nasal discharge, we know that. And of course, any sounds of the respiratory system, we can see that there's some noise there. I mean, children, we can hear that upper airway. You can put your hand on the chest of a child and you can feel that gurgling going on. It's just, is it the upper airway or is it in the lungs? So what is our goal in these things? Well, if it's respiratory, we want to ease the respiratory effort, maybe suctioning the nose out. Remember not to do it too much because overstimulation will increase the amount of secretion. So I would say before they eat, right before they have their bottle, give them, suction their nose out and get that cleaned out. Let them rest. Always, washing your hands. Always, of course, even that child, having them washing their hands, those things. Making sure the older children know to put their tissues in the proper place so that you or visitors or their other brothers, sisters don't get sick. If we keep that temperature down, they feel good. You can see a kid going from sitting in the corner, moaning, crying, not eating, to give them something to get their temperature down and they're normal again. Up, running around, playing, and that's when they're going to drink. So keep that temperature down and they'll be able to drink. I mean, food isn't as important as hydration, especially when you're talking about anything with mucus. It thins it. We can get it up easier. And of course, children always need hugs. It's okay, sweetheart. I'm going to make you feel better. So we've talked about the ear and why we get a lot of those infections. So how do we take care of ear infections? Well, ear infections are a bacteria. It's staph. I mean, everybody has staph in their mouth, their nose, upper airway. It's just normal. So what do we want to do? Well, we look into the ear. We might see that bulging eardrum in there when we look inside their ear. And we're going to be putting them on an antibiotic. Usually the simplest is amoxicillin initially. We'll put them on that, which takes care of a staph infection. Make sure this parent and the child knows they need to take every dose until the end of the course they tell you to take. Twice a day for 10 days, make sure they do it. And another suggestion, because you can hurt hearing and cause hearing problems, go back and have the doctor look at that ear again and check that ear. You tell the parents that to make sure the infection's gone. They might need another course. You don't know, but you want to take care of that hearing, okay? Prevention of reoccurrence. One of the big things is secondhand smoke. Believe it or not, secondhand smoke causes ear infection in children. So anybody who comes to the house, they can go smoke outside or they don't smoke at all, right? Got to take care of your child. And of course, keeping that nose clear, keeping it blown if they're older, and of course, liquids to keep it thin. So if there's any secretions, we get it out. Because once you start seeing secretions, it could go up into the ears, and that's when you get your ear infections. Now, a lot of you've heard about mono, infectious mononucleosis, and it's just the kissing disease, right? So we know it's transmitted somehow by mucus of some sort, but it is a virus. But let's go into exactly what we're going to teach and what we're looking for. Now, it is a virus. It is Epstein-Barr, which sort of is like the fatigue sort of syndrome you see. They won't move. They'll be tired sitting. They don't want to play. You're going to see that fever. They're going to complain of a sore throat. Usually the sore throat and fever and the tiredness gets them to the doctor's office. And they're going to act like they have the flu, the body aches, the swollen lymph glands. And if you look a little closer, you might see that their liver underneath that right rib cage or the spleen underneath the left rib cage could be a little swollen. And those are the things we'll be worried about, okay? So how do we diagnose this? Well, usually they come in, it's a sore throat. The doctor's going to test for flu always, and is going to test for strep throat. And they're both going to be negative. So they're going to say it is a viral pharyngitis, tell you to give them the acetaminophen and ibuprofen and increase fluids and rest. Well, 3 days, 4 days later, they're still sick. They go back to the doctor, and the doctor says, well, everything was negative, but let's just put them on antibiotics, which they're on 3 or 4 days. And then all of a sudden they say, you know, this isn't working. He's still sick. There's something wrong. And you'll take them to urgent care or for another opinion, right? Or an ER. And we hear all those symptoms and what will happen? Well, we're already thinking that this could be infectious mononucleosis. So how do we diagnose that? Well, we'll do a CBC. The white counts are normal. It's a virus, right? But we'll do a monospot test. And this monospot test tests for mononucleosis. Now, we get a positive monospot test. So it's still a virus. We're still going to treat them the same way. But what is the thing that's the most important about mono? Well, I told you the liver gets big and enlarges, and so does the spleen. This child has to be on a physical education, any sort of activity that could cause the abdomen to be jostled or fall on it, on their abdomen. Brothers and sisters can't be beating them up on the floor like my brothers used to do to me all the time. Nope, you can't beat up your sister because we need to protect the belly. Now, what happened? Well, of course, absolutely no contact sports. So I had a little boy. He was 9 years old, came in with his father into the ER one Saturday morning, all that scenario I just said. And we said, yes, he has mono. This is a test. Look, there it is. It's positive. I show it to him. I said, this is what you have to worry about. Well, you need to protect that belly because if the spleen or the liver, usually it's the spleen, will burst, you've now got just internal bleeding and they will die. So I explained it to the child. I explained it to the father. I had a great physician working with me, Dr. Perez. I'll never forget him. He was Lopez, amazing man, really did good teaching. Told him no physical activity that will hurt the belly. He needs to be on rest until cleared by pediatrician in about 3 weeks. Well, 1 week later, I was the primary trauma nurse. And I get a call, kid was on a trike in the Everglades, and the kid fell off and fell on a rock on his belly. And it was my kid who had mono a week before, and he arrived to the ER and he was already dead. He internal bled out. So kissing disease is not just a little thing. And even though I had taught, the doctor had taught, I had talked to the child, he's 9, he can understand these things. He wanted to go on that trike and they let him go. And it's like a big motorcycle. And his brother was going fast, fell off right on the belly. And by the time we got him, I'm telling you, I am still traumatized by this. And this is quite a few years later. So again, teaching, no contact sports. All right, another thing that we get with your respiratory things is croup. And croup is that barking cough that you'll never forget once you hear it. I mean, a kid walks into the ER, you can hear it on the other side of the ER. It's just very distinctive. And you know it's, croup. Again, it is a virus, but it's swelling of the larynx, trachea, and bronchus. And it causes that narrowing, causes that bark to come on. And again, as I said, it is virus. I'm going to go further and tell you more about it as we continue. Now, bronchitis is tracheobronchitis. The bronchus gets really inflamed. What's significant about bronchus, you don't have that seal-like barking that you hear in croup, but it's this dry, hacking cough, non-productive, that when you try to go to sleep at night, it is the worst and keeps you awake all night long. This is the one that as an adult, they'll probably give you a Z-Pack, give you a Medrol dose pack, steroids, and most likely some sort of cough suppressant so that you can sleep. But bronchitis, worse at night, dry, hacking cough. All right, so the laryngotracheobronchitis, croup, right? I just talked about it. These are different things. Mostly, again, it's the virus. Now, when do you see croup usually? Now, it's usually after you've had this, mucus, cough that's been going on for a while. What do you see with croup? It is inspiratory stridor, okay? Hard to get stuff in, swollen, everything in there swollen. And the epiglottis starts to get swollen, so it's hard to get air in. And because of that, you're going to see substernal retractions. Again, that cough is going to be there. So again, how do we treat this? Well, we want to stop that respiratory distress, and we want to stop that lack of oxygen, because you can't get air in there. Now, if we don't take care of it quickly, which is just a steroid, again, it's a virus. Many of them get one shot, a group of pills, some liquids. It's all different ways depending on the child. But if we don't take care of it, it's going to lead to respiratory acidosis because you're not breathing right? And you can get stuff out, but you can't get stuff in there. And then, of course, respiratory failure. And if you let croup continue, remember, this is all upper airway epiglottis. That epiglottis gets so swollen now because it hasn't had a steroid. You continue to cough, continue irritation. You get acute epiglottitis. This is a medical emergency. Now think about your epiglottis is that leaf-like cartilage that covers your trachea when you swallow, so that food doesn't go into your lungs, right? All right, now it's swollen all the time. So what are you going to see? Well, of course, you're going to see you're now getting more hypoxic. You can't get air in. Inspiratory stridor, really bad. I mean, you try to position, you'll see these children leaning forward, leaning to the right, head up, to try to find that one little piece of area that they can breathe through. I mean, it's really a process. So these kids, again, tripod positioning, usually leaning forward helps, but they can't even breathe, so they can't even swallow. They're drooling, okay? They're going to talk, but they're going to hear like that garbled because they've got mucus in there and they can't breathe, and even talking is going to be difficulty. And it's a frog-like sound when you trying to get air in there, okay? So of course, all the retractions are going to be there. So what is our nursing priority when we see this child? Well, number one, this kid comes back immediately. These children are put right into an area like a trauma room, if they have one, or a room for emergencies, and we'll be there ready to either intubate or put a tracheostomy in this child immediately. Our goal, we got to do something to maintain that airway, okay? So we're going to try to decrease the swelling in that epiglottis, to decrease the size, to allow air to be able to go in the trachea to get oxygen. Because by now, you're becoming restless, you're hypoxic, you don't feel well. It's like you're getting even dizzy because of no oxygen. So we're going to be given epinephrine. It could be in an injection sub-Q, or it could be epinephrine aerosols. We're also going to be given steroids. IV is your best because it works the quickest and it decreases all that swelling in there, okay? And with that, it says, maintaining hydration. That's not your initial. That's more of a long-term outcome, but we are going to be giving oxygen to that child. And the moist stuff tends to go down easier. And they have these little moisture sort of face masks that we can put on, and giving oxygen to that child. So that little bit of air they're getting in there will help them breathe. So as I said, epiglottitis is a pretty dangerous thing. Now, RSV, like I said, is from winter to early spring. It, again, is a virus. You and me, common cold, but we're going to give Synagist, which is also one of those biologics, okay? It's palivizumab, and it's once a month for like that 6 to 8 months, depending, okay? And RSV, how do we take care of these children? Well, what we're going to do, again, clear the airway, okay? If they can't breathe at all, it's going to be IV fluids. If not, they're given a lot by mouth. It doesn't mean if they have RSV, they need to go in a hospital. If it's a normal, healthy child who just needs us to teach them how to clear the airway, give them time to breathe and time to, eat their bottles, they'll be fine. And they can go home. And we'll tell them if it gets worse, you see increasing retractions, respiratory distress, and of course, bring them back. And another thing, there's 2 words used for RSV, bronchiolitis or RSV. So there's 2 words that we use interchangeably.
Professor Bogart.
Sure.
It says we have a quiz 3 today. I don't know if.
Oh, we'll do it after this. Thank you very much.
Okay.
Thank you so much, Ashley. I completely forgot that one. It's okay. I loaded them all yesterday for all of the sections. I shouldn't forget. Thank you for reminding me. You want to guys take it right now before you forget? It's up to you. Tell me. You know me, I'm open. Let's just do the
Yeah, now it's
PowerPoint.
fine.
You want to do it now,
Okay.
everybody?
Yeah, I'm good with now.
Not a problem.